It's not real. Okay. I didn't respond anyway.
We're about to start. Yeah, good evening all. So I'm going to officially open this meeting, and I would like to welcome the committee members, the officers, the members of the public and the press to tonight's meeting. Just a few administrative matters. So first of all, I would like to advise you that in the event of fire alarm, everyone should immediately leave the building through the nearest door and assemble in the car park near Clarence House. For those of you who would like to use the Wi-Fi, the password is greenshine11, all lowercase. The first official item, we have apologies for absence. So we have received apologies from Councillor Chandler, also apologies from Anna Fernandez, but we have Councillor Neil Hopkins deputising on her behalf. We also received apologies from Councillor Simon Shelley. We have Councillor Carol Shelley deputising on his behalf. And also I would like to let you know that Councillor Barbara Parry and Nigel Green should be joining us online. Hopefully that works. Are there any other apologies? No, thank you. The next item we have declarations of interest. I would like to remind members to declare any no interest in any matter that will be considered at today's meeting. Are there any declarations of interest? Councillor Lunch?
Yeah, usual very useful primary school and everything academy.
Thank you very much. Councillor LaQuay-Green? Just the usual from the Albert Oxford. Thank you. Councillor Howard?
My daughter works for Swindon Social Services. That's it. And I'm a health visitor in Wiltshire.
Thank you very much, Will members. The next item we have minutes. So we have two sets of minutes.
Sorry, Chair. Sorry,
Yeah.
Can I just declare an interest that I work for New College Swindon, please?
Thank you very much. Good to see you online.
Thank you.
Thank you. Okay, so that's noted. So the item 3 is minutes, two sets of minutes from meetings that were held on 13th of February and 17th of March. So I'm going to start with 17th of March. Would anybody like to raise any corrections?
Yeah.
Yeah, Councillor Davies?
I think it's 17th of March, which is good. But yeah, page 17, I think you've got Claire Curry working for Health and Children.
Yeah, thank you very much for spotting the mistake. We will make sure that that gets fixed. Apart from that, are councillors happy to agree with the minutes? Cool, thank you very much. Thank you. So we can move to the next set, which we have minutes from the 13th of February. Are members happy to agree the minutes as a true record? Yeah, I can't hear any objections, so that's great. Thank you so much. The next item is public question time, where we allocate 15 minutes to the public to ask questions. I don't think we have any members of the public tonight, so no questions. And this means we can move to the item number 5, which is Standard and Multi-Agency Safeguarding Match. I'm going to invite Councillor Nixon and Lisa Almond to introduce the report. Over to you. We have David Goldsworthy. Would you like to join?
Yeah, thank you, Chair. So, yeah, I'd just like to introduce this report around the Fundal Multi-Agency Safeguarding Hub. I'm aware that some members of the committee have already visited the MASH in the past few weeks, see firsthand. Lisa and David are on hand to answer any further questions around the reports. So I'm going to pass over to, do you want to start, Lisa, or David?
the amount of referrals that come into the front door. The front door does remain work in progress. You will see from the report, we do receive a high number of referrals into the service, roughly around 1,300 a month. And that's been consistent for the last 12 months. Our highest referrer is our police colleagues, followed by our health colleagues and then education. And they again have remained consistently in the amount of referrals that they contacts they're referring to us. We did share, be it somewhat late, a data PowerPoint. Some people now, which shows you the sort of consistency in that. We are with the referrals and the into children's services. We are in line with our statutory neighbours and with the England average. We have undertaken quite significant training. You'll see in the report with our partner agencies, and we've got dates planned for every month in this year. And they accommodate, we've done 300 staff so far, multi-agency staff. We need to do that for around 25, 26. Our conversion rates for contacts into assessments is quite consistent again, and is in line, is below the national average in our staff neighbours. And I think that's because we include the information sharing into our numbers. But that again is consistent around the mid-teens, up to 19. And again around staff discussions, that is in line with national averages. Is there questions that anybody wants to ask? Have we reviewed the report?
Well, thank you very much for your introduction. Yeah, we can open the debate for two, but I would also like to say thank you so much to Councillor Dixon and Lisa and the team for they allowed us to do lunch. It was really good to actually see how it works on the ground and how they sit. Thank you very much for that. And we can open the debate and ask questions. Councillor Davis, you wanted to ask questions about this one?
Yeah, inevitably. So can you just explain what contact sources means? Police, health, education. Is that where it comes from? If so, do none come from outside of those? I'd expected some from public.
They are our top three. As it says, top three contacts. If you look at the bottom graph, it does show the other agencies, but they're our biggest referrers by far, and there is members of the public that do refer in. I think that's around about consistently around about 6%. It's quite a low amount, and it's the other agencies at the bottom as well.
Yeah, still processing. That's fine. Thank you.
Thank you. Councillor Coyne.
Hi, thank you. I just have a couple of questions, that's okay. In terms of when you say health, is that mental health and kind of general health, or what is health, if that makes sense?
Health is it's all the health services put together. Our system currently doesn't allow us to split up mental health from school health and health visited. It doesn't allow from hospitals. Vast majority of those referrals are from the hospital, but our system keeps everybody together. Same with education. It's very it lumps everybody together in one day.
And then I just had a question about, is it okay if I ask a follow-up?
Yeah, sure.
I just had a question about the conversion rates, which on the one hand, are really impressive, and I think there's been a huge amount of work that's been done. But I just wondered, when it's 90% of all contacts progress to social care referral, which is lower than the national average, is there a context for why it's lower? Is that because our thresholds are higher, or is there kind of a narrative around that, if that makes sense?
I don't believe our threshold, I think our thresholds are now consistent, so we apply the threshold consistently. I think it is lower because we in our figures, we do include all the information sharing with other local authorities. So if we share information, we get a lot of information shared with us. It's blue contacts, the main report are the information sharing ones. A lot of other local authorities do not include those figures in the overall counting where we do. That figure would probably come up to the average of around about 30% if we removed all those blue contacts. So we are, our data is consistent with the national average. It's just the work that we have done and the work that we are trying to do to make sure the right children get the right support, and that's about applying the thresholds and moving children through the MASH with the right help, the right outcome.
Yeah, would you like to, one more quick one?
Sorry, just one more quick one. In terms of that threshold and the re-referral rate, are those re-referrals coming back? Is there like a narrative around the re-referrals as well, if that makes sense?
Our re-referral, keep saying our national average in statistical names, it's on the line with that. I think it's 26%, isn't it, currently? Or it's there or thereabout. The difficulty, we would want that to be zero. Do you know what I mean? We would want that. We would want to deal with every child that comes through once and progress them. But the difficulty is that children have different needs at different times. We will always have a referral rate, but we would want that lower than it is. But at 26% is the mileage with national average and statistical numbers.
Thank you. Thank you. I have a few hands.
So we do a deep dive on all our referrals, and some of the reasons why. So quite a number isn't just about the same child coming back. So it could be a different problem, could be a different family situation. Sometimes, somebody else comes into a situation that then worsens. So there's a number of reasons in their dip sample and having a look at.
Okay, that's really helpful. Thank you. So I have a number of hands. I just wanted to have follow up on David said. He said, yeah, I'm sure that thresholds are applied consistently because that was the areas which applied offset. How do you assure yourselves that they are applied consistently?
That is a good question. It's about we've now moved to a system where we have the same person that is working the inbox where our referrals come into, so it's a consistent person making those decisions. We do a lot of dip sampling, we do a lot of audit activity. I do a lot of dip sampling and looking at where the work is going. But it is about us consistently applying the right time thresholds, levels of needs to the referrals that come in. We like I say, we do a lot of audit activity. We do a lot of dip sampling. We have multi-agency audits. We meet with our police, health, education colleagues to look at a number of cases. We've done a lot of dip sampling on our no further actions, the ones that we haven't took any actions on, and we use that to inform ourselves where we are.
Thank you. So would you describe our processes internally? Do you also do any training in relation to make sure that partners' understanding of this threshold is also consistent?
Yeah,
I think now.
we're doing a significant amount levels of need training with partner agencies. As I said before, we do that on a monthly basis. We are working within the strategic match board as well to make sure that the levels of need guidance is implemented with our partner agencies, and that everybody's got that awareness that everybody knows how to apply those thresholds.
Thank you. And how do you measure progress? Just this is another area restricted of that.
I was going to say that actually. So the Right Help, Right Time, that document is owned by the Save for Children and Adults Partnership, so it's multidisciplinary. So they oversee the Right Help, Right Time document and thresholds. So the partnership, we are a partner in terms of SBC children and obviously adults. So it's not just about our thresholds, it's about how we consistently communicate that out through that documentation. So training is regular and monitored and evaluated through the partnership as part of the overarching business plan as well. So just to give you some assurance that there is another multidisciplinary executive partnership that oversees our work as well.
Thank you very much for that. So I'm going to hand over to Carol Shelley.
Thanks. I just have a couple of questions. Just coming back, Lisa, to something you just said about partners. Partners, does that include school partners, teachers?
Yes, that's right. So you'll know that education isn't a full statutory partner in safeguarding, although later this year we are hopeful, but through the Working Together 2023 we have done extensive work, which I think David highlighted with education in terms of referrals. There's an executive member, which is a CEO trust lead, and then there's now a new practice group that sits in the Safe Children and Adults Partnership that's the representation of heads across the borough.
So when you gave the number of 300 people being trained, that would include the other schools, from schools.
We also do, though, extensive training through the DSLs, designated schools leads, and the education, safeguarding education team, which is in education but sits within children's services, works across as well to do regular training support, and David's service in the front door has an education rep. So that education person gives advice, consultation and support to schools that call in, and also sits as a representation as part of the strategy meetings when we collect information in relation to children of concern.
Brilliant. So I was going to say that 300 was a pretty impressive figure. I just wanted to clear that up. I did have a question under 3.6, where you're saying 3,842 cases class of information sharing, and this is remains an area of concern. Can you just expand on what you mean by concern here? Is it because there are too many people or too few?
I think David alluded to the fact that some local authorities don't report, and we may look at that when we move over to the new liquid logic, because the system breakdown that you refer to, Councillor, is much easier on liquid logic. But at the moment we're with quite a difficult system, so we can't break it down. But we would expect at the front door to be able to put more on our media, to be able to deter information inquiries really, and there does seem to be a culture here that we're still addressing with our partners and the courts to be able to find a different way to constantly contact children and families, contact Swindon to seek information that actually we can find in other sources. It's of concern because it distracts the staff and slows them down when they're actually working through the numbers of contacts that come through the month, where you could be dealing with something a little bit more appropriate, and so that's probably why it's raised as a concern.
Thank you, because that really sort of clarifies that. It wasn't that clear in those couple of sentences. And finally, I have one more question to ask. I'm trying to be really brief. Under 3.12, it says here that we're going to have a triage hub, and it's going to be in place, fully operational by the end of April 2025. So we're in April. How's that happen? Just want to hear that it's happening the same rate.
See, go on, sorry.
Fastest finger. Yes, we've moved gradually to that position. because we want to make improvements that last. But we are there, we have got a triage hub and our, the safeguarding MASH sits behind that now. So we are there now, so we're doing that slightly.
So Councillor Shelley, the contact, Children and Families contact Swindon, it was a contact Swindon, but we were getting all manner of different inquiries relating. So Children and Families contact is the triage. So this, the new model is very much geared up now for the new pathfinders, which will be, coming through in terms of the Department of Education this year and early next year. So the triage hub is where all of the information, all of the requests for service come into. They are triaged in terms of importance. If there is it's really clear from the information that's shared that it meets our requirements for a referral, it goes straight into our assessment team. If it's quite grey and we're unclear and we need further information, we feel there may be some significant harm, it goes into our multi-agency safeguarding hub. Half of those contacts step down into early help, so and we want to do more of that. The numbers need to be much more impressive in terms of the huge amount of early health intervention and support that we've got available. And then the last is the advice and information no further action, which is there. So that is the triage front door, and that sits in front of multi-agency safeguarding.
I just want to say well done for hitting that target for the end of April then of 2025. And my very last thing is Councillor Simon Shelley did want me to pass on again his thanks for the visit to the match that he made. It was really informative. Thank you.
Thank you. So I have a few hands. I'm going to prioritise people who haven't spoken yet. So I'm going to go to Councillor Lodge.
Thank you very much, Chair. So mine's quite a quick one, and it's in response to a question someone else asked, just to check that it's based on your response to that question. And I may have taken you a little bit too literal, so if I have, I apologise. But when you were talking about the Daily Mail's clearance, the triaging, which I think that's a really good thing that you've implemented, and you referenced that one of the ways in which I inferred from what you said that the way that you've achieved better consistency is by having a consistent approach to that mailbox, but it sounded like you have achieved that by having one person primarily doing that. So so just to clear up, you have got more than one person doing it.
We've got quite a few people doing it, but to get that consistency, it's somebody's role to do that consistently now. But there is a number of managers doing various different levels of scrutiny, doing different levels of work and moving it through the system. So yeah.
Brilliant, thank you.
Do you have any follow-up questions? Or any other questions, Councillor?
No, that was it.
Thank you. So I'm going to go to Councillor Hopkins.
Thank you, Chair. I think we can all have a high level of confidence that young children and young people are referred to the service from wherever that referral comes are going to be looked after in a very caring and careful way. I just have a slight concern is that something like 25% of the referrals come from schools on average. But there's also a cohort that are homeschooled where there's no school, if you like, picking up the pieces if something's going wrong. So is that a gap? Is that an area that we do have to have some awareness of? Because if they're not picked up by the school, they might not be picked up at all.
Yes, Councillor Hopkins, I think that's a fair point. I think national policy this year will rectify the need for a register for children that are home educated. There's a number of tracking systems, mainly through the GP or any other services that the young person may visit. But no, we can't go out unless obviously the issue is raised with us as a concern. So I look forward to any changes in legislation that will allow social workers to respond.
As do I.
Thank you. Councillor Howard?
Brilliant. Most of my questions have been asked actually. Thank you. And the MASH tool was brilliant. Thank you very much. And mailbox clearance or something you shared then, and that was a really positive step, as well as many other things. I just wanted 3.7, the membership, the additional members of the exploitation league, missing needs, educare. I just wondered how we are assessing how that's helped really. Was there a before or after? Have we seen differences that were measurable to getting all those people involved? Because I'd imagine, yeah, that's kind of one. How do we know before and after that it's working better?
It's working better because we're having better conversations about young people and the agencies that need to be in the room are there now, so we can have those conversations, which means that young person gets a better outcome. How we measure that's all been in place since Christmas, especially in respect of the missings in the OPA, which is the child exploitation team, and housing. So we need to work out how we measure that, but it is about meeting needs of children and young people, and the more people that we can discuss those with, the better for that young person is.
I do agree, but it would be good to have something, it'd be nice to have something concrete, like, we're picking up children earlier, or we're having those conversations, so they're not going missing, and that sort of thing, because otherwise it might just be that everyone's getting to know each other really well, having good conversations about children, but actually it's not making a difference to the children, and that's really what we want.
And some of the stuff with the missing coordinator, the child exploitation is about that. It's about being around for that morning meeting, which is last night's referrals or work that's coming overnight or work that's pending for that day. So it is about, like you said, catching people earlier and having those discussions. And it works. That's how matches should work. Is that the referrals come in and the people in the room to deal with those referrals, and that's the stage we're getting to now.
I guess we might have it, if it's only so new, we might be able to look over the year whether,
I certainly know that obviously right help, right time, right child, if you've got the right people in an integrated, co-located model, not only sharing information instantly, you're responding quicker. Particularly around exploitation, and educare. There was a process prior with educare that it went through a referral process and it sat and waited and that. So if they're there and they know it's more pressing, they'll go out and respond within the social work time. And also that nugget of information at the time of joining in those check and challenge meetings on a daily basis or an individual children's meeting could be that final piece of the jigsaw that will make a decision that will allow us to either move more promptly or be able to prioritise other children. So it's really hard because part of working together is about doing all of that and doing that well, and all we know is that means that children's information doesn't slip through the agencies. But it's really hard. I think it's a really fair point that sometimes you can't measure the actual, you just know that works better for speed and promptness and shared responsibility as well, which is something that I think co-location is really important, that agencies don't feel that they're just on their own when they make decisions. I think partnership work and sharing that responsibility makes for much more informed decision making.
Thank you. Councillor Davies.
Thanks. Just returning to the PowerPoint, it would be really useful to get these in advance, of course, even if it's just half an hour in advance.
That's my apologies. I did send them out this morning, and the lady that does all of my data has been on annual leave.
Yeah.
But I didn't see when I read the report that there wasn't any data, and I do know that you like data, but also I think it's a visual that you can take away. And so apologies if you didn't get it, but I did send it out this morning.
You said you rang to your councillors?
To community services. First thing.
Do we get it? Yeah. Sorry? Oh, okay, fine. Yeah, if they could be circulated in the future, that would be fantastic. And so in this, I'm a lay person from this point of view. So sentences like 65% of scrap discussion progressing to an S47, they're a little bit difficult. Could you explain the second?
No, they love it. Children's social care. So a strategy meeting is called where after, and you probably saw if you went into the match, so if there is cause for concern in terms of meeting the threshold for likelihood of actual significant harm, then a number of core agencies come together in what they call a strategy meeting. They then make a decision from sharing all of that information to then decide whether it's going to go into a full child protection investigation. So that's the conversion there of those meetings into investigation, and then that investigation into complaint.
So what's the S47?
That's the section 47 part of the Children Act 1989. So that is the piece of legislation that allows agencies to come together and override consent, share information in the best interest of children.
Thank you. So the 19%. So what's so step it through. So 30.
So let's walk through the conversion rates for you, councillor.
Yeah,
I think it's a really fair point.
So what percent don't go anywhere, I suppose, is the question.
Which ones don't go anywhere?
So if someone brings up,
Yeah.
is one of these bars no further action needed?
No, not on the documentation that you're seeing.
Okay.
All of these are conversion rates. One of the things that we are really keen on and that will imply that we are doing the right thing and that the right amount of information at the right source is coming into our front door is our conversion from X to X. So what you look for is a really good conversion from a contact, which is when someone just brings up and has information. A conversion is a really good from a contact to referral, which means that it's the right level of information for us to make an informed decision to take it into social care, into referral, or into early help, depending on the pathway. The next conversion is where you're raising an issue where there's a level of significant harm. We would want to see a good conversion from a strategy meeting into an investigation, because that means that we're not meeting and talking about families without their consent, and this is absolutely necessary when a child's at risk. The last conversion is from that investigation, we have a duty to call a child protection conference if that investigation indicates with the police that there is a cause for concern. Again, we don't want to be putting people through unnecessary investigation unless there is the evidence at the end to be able to call those agencies together and put a child on child protection. So the higher the conversion, the more we've got the information, the more we've got the right children being taken into the protection that they need.
So there would be that. Really
No, go on, it's fine.
So 90% is less than 34%. Is that good or bad? Is it good or bad that it's lower, I suppose, than the average, than the national average?
19% of contacts progressing to social care needs to be higher.
Needs to be higher, right? Okay.
Yeah.
So it's like
I would want to see more. I would want to see more. The higher the conversion, the more appropriate the.
So is it like a funnel? So if everyone rings, so people that ring up or go online. So we're saying that 19% of what's the first funnel? So 34% of those
Contacts or referrals, yeah.
So 19% of those contacts, something happens with.
They go to social care, so they go into a statutory service.
Does that mean that 81%? What happens to those?
Well, about half of the rest go into early help, which I think needs to be higher, because what we want to do is work with families at the lowest level possible. Some don't go anywhere because, as David said, they're just asking for information. You know, can I have a bit of information to complete a court report? Can I have some information on the family that, you know, I'm doing something else? And so we have to make a decision about whether that's in the interest to share that. We get an awful lot of contacts from the court to seek information about whether we know a family, particularly around custody and contact issues. So it's about where it needs to go. And it's almost, I mean, the bar charts aren't really, I mean, the way that Care Director at the moment produces the information isn't the easiest. You'd want a pie chart really, wouldn't you? In terms of which part of the pie goes where, I think that, so we will be able to do that when we get liquid logic for you at the end of the year.
Thank you. So
So
back to my problem. So 19% go to social care.
Yeah, some go to social care.
Yeah. And then is it 60? So looking at this class here at the end. Is it that 65% of that 19% then go on to?
Could potentially, yes.
Is that?
Yeah. Percentage of that. Sometimes the percentage is the same level of 19%, and then a percentage of those could meet the criteria. So the child could be at immediate harm or have an issue of harm that would require it to go into that strategy meeting.
Got it. Okay. And so just I'm looking at so that makes sense about the early help. So is that 19%? So is that 19% on the previous page? contact sources and outcomes. So if we, Q4, isn't it?
Yeah.
But that's in months.
Yeah, so this is February data, because unfortunately we don't have, the data completed for March,
So-
because as you know, we work a month behind.
So if we ignore the months though, so which of those bars down the bottom would the 90% represent? Statutory assessment, I don't know.
Yeah, the statutory assessment one, yeah. This looks, if you get this in colour,
Yeah.
just, it unfortunately is
Yeah.
printed in black and white. And if you get it in colour, it just stands out a bit more, it's a bit easier to read.
Thank you very much.
Yeah, you can put it up on the screen.
Right.
I was gonna say, I did email it, I did print it.
Quite right, it should be printed in colour, but if that helps, we can.
Yeah. Yeah, so it'll be 19% of the 743. Oh, no, that's the contact sources, yeah, no, we haven't put the actual information on, have we?
It's not there, is it? No.
So we normally have, as David said, we normally have about 1,100 contacts a month. I would like to see that go down, that's a huge amount of work, but it's not the highest in the region. And then it's 90% of those moving through into the statutory process.
And is
So
that,
that to me, sorry, Councillor Lewis, that to me is too much is coming in to ringing up, which is not going to be needing social care intervention, which as David said, a lot of that work could be filtered in a different way by putting, I think, personally more information on our website, by thinking about the amount of advice and information that we don't need, and I think we've got quite a bit more work to do with partners, particularly midwifery and other sources that just think that they may be contacting us to want us to tell them something which we're not supposed to tell them, and it creates delay in the system. So I think there's a lot more work to do with our partners, and I think they accept that.
Thinking to.
Yeah, sure.
no, I might follow up by email, but I don't think.
No, do that, because I think the data is really confusing how it is. It isn't the easiest, and I'm really happy to walk you through the key performance. It's really important that you, because in terms of scrutiny, you need to know that we're making the right decisions and the percentages look right. And so I think it's a bit more of an informed discussion, which I'm happy to have with all of you, or accept those sessions.
But I would suggest maybe next time, if the slides are circulated this week before, then
Yeah.
you know, we would have opportunity to see.
As I said, I'm sorry, when I read the report coming back from leave, I saw there was no data, so obviously had to wait for data, but it's a good point, and I will make sure
Yeah.
officers.
Thank you very much. I know people want to speak, but before I give say anybody in the room, I want to ask if anybody online has a question. Okay, I'll take it as a no, so Councillor Hodge.
So just a quick follow-up on what Lisa was saying is that I've worked with schools in safeguarding, and I also do a lot of voluntary youth work, and quite often in, how can I put this, less aware and less skilled agencies, the mesh is used as sort of like almost a consultancy service sometimes, where people do phone up. Just, I don't want to say to cover themselves, that sounds a bit wrong, but they phone up to check whether there is an issue or not, or something that needs taken forward. Is that kind of where you go? There's a lot of stuff that you get that is not necessarily actual.
I think there is a lot of worry in the system,
Yeah.
you know, there's a lot of media attention, there's a lot of pressure on partner agencies that don't, you know, even in safeguarding, you still, you know, we've got checks and challenges, we have professional conversations, so I would always advise any professional or anyone from the public that's concerned, you know, give us a call and let's talk it through. But there are some limits where, you know, but we do a lot of training as a partnership. We're always happy to offer. We are looking at a professional consultation line, but these just come about as we progress through our improvement work.
Thank you. Can I also ask on the statistics? So obviously there are referrals that have been split into different categories and different levels. I understood that from the report, and they come with attached SLAs. How do you ensure that they are actually processed within those specific timeframes? Do you have any data on that?
On time frames?
Yeah. how many referrals are actually processed within those SLAs and how many are processed
Oh, I
outside?
see, okay. So this will be the grad rate. Do you want to give any?
Yeah, so the, in respect of the reds, which are the child protection, the immediate, action ones, for March, give you, I'll put that in the report next time, but for March, we've got 100%, which is good. The ambers, which are likely to be an assessment, but we may need some more information. We did 60% of them within the time scale for March. And the greens was 48% in the time scale as well, for the whole of March.
Okay, thank you. And blues?
And blues are information sharing, so we have them for 5 days. I think that was 85%
Thank you.
for March.
Thank you for clarification on that. I'm going to go to Councillor Cook, who's been waiting.
Actually, it was answered by Mike Davis. So, thank you. I just want to know what S47 was, and I wrote down what the answer would be. Thank you.
Thank you. Councillor Coyd-Green?
Thank you. Sorry, I was just to head back to what you were saying, so that's okay. So my understanding is that the 64% percentage is to do with those partner agencies and then maybe some misunderstanding of thresholds, etc. And I just wondered, for example, in my agency, we have our own internal MASH that we would contact prior to contacting MASH. Sorry, I don't know.
No,
But this is using very professional language.
We can go with Mash
And I wondered, when you said about the midwifery, etc., does the DWH and do they not have their own internal safeguarding infrastructure? Is there a cultural dilemma maybe within internal safeguarding infrastructures that is there a relationship that can be kind of formed in a different way around that, if that makes sense?
No, I think that's a really good question. All agencies should have a designated safeguarding lead. There's one attached to every school. There's as you say, in all health, everybody's fully trained in terms of safeguarding. So we always would expect professionals within their own organisation to share their concerns and worries and check out what they want to do. And then if they're still concerned or they feel that they should err on the side of caution or there is valuable reason, it will be taken into the contact. And then we will make a decision and give rationale for where it goes on. So yeah, it's really, and I think that's something that is really progressing, particularly in health. I think they've been really thinking about how they can develop their own safeguarding support. But they come on, they're the professionals that come on the training through the Safe Children Adults Partnership. They're the training that their representation sits on our strategic MASH board and operational board, so that keeps a consistent level of communication. They're also the agencies that do a lot of the multi-agency auditing that David references, so they keep their knowledge. And that's how you keep that level of consistency and threshold, because you're having those conversations and agreement, and then you're sharing that decision making on that casework. So it's just, all of that builds up into confidence between partners, and some using it.
Thank you. Any other questions from the committee members? Councillor Hess, I also had a question around, you mentioned the rollout of liquid logic. I was just wondering how well are staff prepared for the rollout?
So we've got our pathway now. All our staff have been involved in the development of Liquid Logic. As you know, Pete Campbell, who is the Director of Safeguarding and Sport, has gone over to Conduit for the full year, so that we are very practice-led. They're really excited. They haven't started the training yet, so let's ask them when they've done the training. We're rolling out the modules all the way through the summer. So obviously certain parts of the service will go to certain modules. There'll be core aspects of training they'll have to go on, and then depending on the specialism, they'll go to their specialism. So it's going to be a really busy, detailed training program. So yeah, I mean, they're prepared in terms of motivation and wanting to do that. They're doing a lot of cleaning up of the information so that when it migrates over, but they haven't started the full training program yet. So it's early days, and happy to share the program with Scrutiny.
Thank you. And also sort of like an overarching question. So from your perspective, what are the three main areas where would you like to see more progress to be made before the next inspection?
I definitely want to see more progress in the front door. I mean, as I said, it's a partnership owned multi-agency safeguarding hub, but I think the figures are still not where they need to be. And I still think that, we've had a recent DFE review that says that we are making progress, but, it's still slow and steady, and we still need to do more to build confidence at the partner agency schools and the police. We still need to work with the police about why we're having a lot of information come in that actually we don't need to know. So there is some issues there, and the police are very aware this is a national issue, this isn't just a Swindon issue, but we will continue to do that. So we definitely want to make progress in our front door. If we don't get the door right, as you know, as a partnership, it makes it very difficult for the children through the process. We're due our monitoring visit in May, so I'm hopeful that we'll get the call at the end of April, and they're looking at our children that we care for service. So we're prepping at the moment. So we've got some areas of improvement around some of our case recording and our visits, so everybody is absolutely catching up on that and making clear. So I think that's a real clear improvement in terms of really working on parenting, on really ensuring that the children that we have are in the right home and in the right place, and doing a lot to bring children back into borough. So I think that's a real priority area. And the last area is obviously permanence, where we've been working with children through their processes. We want to make sure that we have worked with them and supported them into their stable permanent home. That could be going home for many children where situations are now safe and circumstances have changed. But for many, it's about securing them educationally and therapeutically in a foster home, and making sure that they have a really good start in that process and support them going on. So they're the three main areas for us in the next 3 months, and then we'll reevaluate where we are after the monitoring visit.
Thank you. Now I'd like to go back to committee members. So obviously we had a discussion this evening. Which sub-area would you like to focus? Because I think we should keep our eye on match, because it was raised by Ofsted, and it's very important as studies so that we get it from the right. So would you prefer just to have same style update, or would you like to focus on specific areas in the report? Are there any suggestions from anybody? Councillor Coydry?
I wanted, if we might have a kind of update now that the triage hub is operational, on kind of the efficacy and output of that. That was what's coming up for me at the next meeting, well, not next meeting, kind of at the interim meeting.
Could you do that?
Oh, yes, sorry.
I
I was just working it out, I already worked it out. Yes, of course. I think it's really important that from the journey from where the work, if you like, or the information comes in, where it goes, and what you want to do is track that there is more appropriate children moving into early help. So I think the data is important, but I think maybe we need to talk you through a little bit more in that. The other thing is, I think it might be helpful for the scrutiny board to actually follow a child through a process, because then you actually understand some of that. I think that's really important, that you kind of see that child's journey as well. So that could also be included in the work.
Sorry, my next part of my question was, could we have a kind of start to finish process so the young person go through the system? I think that'd be really useful for people who aren't embedded.
Yeah, I think that'd be really, really helpful. Just as scrutiny members as an aside, because it is really complex. It doesn't need to be once it is a pathway, and you'll see that on the liquid logic implementation. But I would also recommend that you do call us back at regular periods for our thresholds and for our front doors. As I said, it's the most important part of our service in terms of the way that we want to work with partners. It will be very key in the new rollout of Pathfinders, as I said, at the end of this year, where we will be moving more multi-agency staff into our teams as part of the new model. So really key.
So I think we really good to find these areas in the report, and also when we're talking about tracking the journey, child journey, I think it would be also really good to understand timings. How long does it take to get from step 1 to next steps? It would be great. Councillor Davies, do you have any ideas?
I'm just interested, in terms of liquid logic, will that allow capturing more data about how service users feel about it's gone for them? I thought we'd be able to get some sort of,
I think the survey is useful. I was going to say that earlier, but I don't know how you get it in.
well, yeah, so I suppose, yeah, sort of feedback at the end or something like that, I don't know.
So we capture feedback at the moment from assessment, not too much from referral. We haven't really thought about that, considering the work is quite pacey, but we do have points throughout children's services where we seek feedback, particularly at the end of an assessment process, at the end or when a child has actually finished work with us, and that. But liquid logic probably will make it a bit easier to access.
Yeah, if we can get sort of examples of, because it's probably quite a hard thing to provide data on, but if just, yeah, how the search users are being impacted, basically.
Would you welcome that to be about children's services in general? Because so one of the deep dives that we're doing for the improvement board is around the voice of the child and participation. So not only the mechanisms, but what is the feedback? We regularly receive feedback. And as part of our framework, we act on that. We act on that feedback. So one of the things that you might want to consider later on in the forward plan is you have young people in, they're always happy to come in, and it's a small enough group, I think, to manage. But yeah, we collect feedback all the way through the process, and we also, particularly our children who are in care, they have regular statutory reviews where children's feedback is part of that review. So that could be a main topic.
Yeah, I think we should include a substantial item, but then also it would be great each time you bring in a report, if you could add specific feedback for that topic into the report. I think it would be really, really valuable work. And speaking of the feedback, I was also going to ask, do you seek feedback from your partners? Do you do something similar?
We do get feedback from partners. We do a lot of the work through the MASH strategic board. We get feedback. We share a lot of information at the MASH strategic board about how we're doing, what our performance is like, what the quality is like, and we get feedback from colleagues there. If say school is wants to discuss what we've done in respect of work that comes in, contacts that are coming, we have discussions with school, we have escalation processes, and we do have quite a lot of discussions with our partner agencies when we are doing the work on the contact me and the MASH as well.
Thank you. Would it be possible to bring some of that feedback into the report? Thank you very much. Perfect. So I think we agree the way forward. So we'll probably bring you back probably in a few months' time, which would be around autumn time, providing we get additional detail, also focusing on user's voice, child's voice, more detail about the personalization and following the child's journey from beginning to end, and more data on timing. Perfect. So thank you very much. Thank you so much, David, and thank you very much, Lisa, and thank you, Councillor Vicky.
Thank you.
So this means we can move on to the next item. And I would like to invite Councillor Brown to join us, and also Caroline Nicol. So I'm not sure who's introducing the report.
Caroline will be introducing it. You will see at the top of the report that it's got Rob Carroll, the interim Director of Public Health, but Rob Carroll is no longer the interim Director of Public Health, so he moved to Dorset in that role on the 31st of March. And obviously, Caroline has written the report. It says it's all her own work, as it were, so I think you've got the best person to deliver the report.
Thank you. So before you introduce the report, I would just like to clarify that you, Public Health, I asked you to report on health nursing visitors, workforce pressures, and opportunities to grow our own workforce. So that was the kind of focus. So over to you, Caroline. Thank you.
Thank you. Hello everyone. So yes, my name is Caroline Little, and I'm Head of Child and Family Health Services at the Council. So yes, I was asked to bring this report as a follow-up to a broader report we distinguished report by our previous Director of Public Health, another one, in fact, Steve Madden, who gave a much broader report on what's happening around public health, and I think there is a specific ask around a deeper dive into public health nursing services. So I haven't actually didn't quite get the information about the staffing side of things, so I do apologise about that. That isn't in the report, but what I've brought is an overall view on performance. I'm very happy, obviously, to follow up on that afterwards. I do apologise that may get lost in translation. Okay, so just as a quick reminder, Public Health Commission, Public Health Nursing Services, that's commissioned by our Public Health grants. However, at the council, we also deliver them in-house. So in a lot of other areas, those services might be commissioned out to external providers, but we are also the deliverer of those services here. They're delivered through our Stronger and Safer Communities department, but we work very closely with children's services, as they're obviously part of that children's system. So the services follow national evidence-based guidance, and there are mandated elements within it. The national guidance is known as the Healthy Child Programme, and the aim of that is to establish good health at the earliest stages of life, where we know we can have a greatest impact in terms of lifelong health. So in Swindon, we have a number of elements to the public health nursing services. The two sort of common elements are around health visiting and school nursing, which you will find across the country. So health visiting focuses on health of mothers in pregnancy and then into the early stages of life up to the age of 5. During that time, there are a number of mandated contacts. So every family is offered 5 contacts during that period. And those alone total up to around 12,000 contacts a year. On top of that, where families need additional help, then will be targeted and more specialist help offered. And their role is primarily around monitoring and supporting the healthy development of those children. The school nursing service is the other kind of common element to the service, which is obviously for our school-aged children. There's open access to all to that service, but it does provide a targeted service. So referrals are made either by a parent or a school, or a child can come forward directly, so particularly in secondary schools where clinics are offered. The school nursing service also ran another mandated element of the programme, which is around the National Child Measurement Programme. So that's where we weigh children in years reception and year 6 to understand what the healthy weight is looking like. We've got 2 additional services in Swindon that we commission as part of this programme. One is the Family Nurse Partnership. So this is an internationally recognised model, which is highly evidence-based, and it's primarily developed to support teenage parents. So we know that young parents face significant multiple disadvantage, and therefore being able to support them at the point of having a child and also preventing that baby from going on to have further disadvantage makes a big difference. In Swindon, we're able to offer that service to our care experienced young people as well, up to 25, which is slightly different to most other areas where it is more focused on the young age range. We've also developed Dads at Their Best in Swindon, which is an equivalent type of father service. So FMP tends to focus on the mother, and by the very nature of the families we're working with, there is often then very little support for the father, who quite often will be in a different household just by the age of the children that we're working with, the young people. So I picked out just a couple of key kind of performance indicators, but again, there's a lot more that we could dive into, so take away further questions.
Thank you very much for the introduction, and no apologies needed. There was a little bit about in the report about the workforce. I think misunderstanding you can blame on the staff changes. Let's do it that way. So yeah, I'm going to open the debate. Who would like to ask question? Liz?
Yeah, just looking at the Family Nurse Partnership, what's the ASQ stand for?
It's an ages and stages questionnaire. I'm very sorry, trying to read all that. So again, this is a nationally recognised measure of child development. So it's carried out across the country, and it looks at various different domains of child development at various different points. So it's used as standard at the 2 to 2.5 year check, and that will look at whether a child is developing at the expected levels.
Okay, thank you. So yeah, so the one that jumps out is bright red is the smoking. Whereas this previous 3 looking at 3.10, Yeah, so previous 3 years, 37.8% means, I think that it's going down from the previous times we've taken, but it's still ridiculously higher than the national average. Yeah, is there anything that we can do to unpick that? Do you need more information on that?
Yeah, absolutely. So with the Family Nurse Partnership KPIs, we've actually got a really broad range of data. So I just picked out a couple here where we're either doing quite well or where we've got some challenges, and smoking is absolutely one of those challenges. We tend to see for all of the indicators across our FMP data that we are higher than the national average in terms of demographic and risk factors. And I think that is likely attributable to the fact that we've got that extended criteria into our care experience young people, which means we've got a broader set of children and young people, but we're also focusing quite targeted way on those children who we know are at risk already. The smoking itself tends to be really tricky to try and break. It's very much built into generational behaviours. And a lot of these young people will still be living at home with their parents who will smoke themselves. Often their grandparents will also smoke, as well as the kind of peer pressures around that. So it is a real challenge in trying to drive down some of that smoking behaviour. What we have been really good at achieving through FMP is smoke-free homes. So raising awareness of the harms of smoke to babies and young children, and ensuring that that is removed as far as possible from those babies and children. But of course, ideally, we don't want smoking at all. So where we have seen some successes in quits, it's been through the very intense work of the FMP team, and will happen towards the end of the 2-year period. It can take that long to see that outcome change. And, you know, as I'm sure you're aware, there are many, many difficulties faced by these young families, and so smoking is not at the top of their list to necessarily stop. But we have also been working on some specific interventions, so there is now a stop to stop pathway in place. So this is being able to offer vapes directly to these families through the FMP service. So we know that by vaping, there is significant harm reduction to the individual, but also in terms of passive smoking. So that's something that's very recently been put into place, and we hope that that will continue. But broadly speaking, the kind of targeted work and keeping that focus on smoking as something that is within people's control and that we can support seems to be working. So as you say, that trend is starting to come down, but we need to ensure that it continues to come down.
Okay, thank you. And can you just explain what, so when it says 32% smoking 18 months, but so it looks like there's about 100 people in this cohort,
Yeah.
Mothers, is that right? Yeah.
Yes.
And so how does the cohort work? Is it the number we were working with in this year?
Yes. Yeah, they're annual figures. Yeah, they're annual figures. So we look at smoking at different points in the child's life. So the 18 months is obviously the age of the child, and we do see families giving up smoking earlier on. So we do see some quite successes in pregnancy, which is really important, and in early childhood. And what we are a bit concerned about is actually that's starting to uptick again when we get to the 18-month point. So whilst it's great, we're not having that at the riskiest point of exposure. Obviously, we don't want people to then be dipping back into smoking as the child gets a bit older.
Thanks very much. Just one last one. Just looking at dads at their best, it looks like that involved 5 dads. Is that right, or is it a bit more than that?
No, it is more than that, but I don't have the exact number of them, so I can check.
I was guessing because there were multiples of 20% in the bar chart.
That's a very good.
It just suggests that it was 5 people.
Yeah, no, I think that's because there are measures of 5 across each of the domains. So what they will do is they'll use these outcome stars to say, you know, you as a dad, you know, how are you rating your skills around money at the moment? And they'll say 2 out of 5, for example. Does that make sense?
It does make sense, but I don't think it matches the bar chart.
Okay. Let me look into that and I'll make sure.
If you could explain that bar chart a bit better, and just let us know how big the cohort was. That'd be
Yes,
helpful.
yeah, we'll do. We've seen about 70 dads to date, so it's a relatively new service. It's something that Swindon have developed specifically, and we're providing national advice on now, so it's been highly regarded. And yeah, so it is kind of work in development, and the numbers are relatively small.
Thank you. So we'll take that as an action. If you could provide us with the information and data, how big the cohort is, that would be great.
Yeah.
I'm going to go to Councillor Shelley.
Just have a couple of questions. Looking at your table, we've got 1.7 on page 30. We've got here percentage of children turning 2.5, who 79.4%, so no, we've gone up to 80.5% that are having that visit. The 20% who are not having the visit, could you tell me about who they are? Are they a particular group, a disadvantaged group, or are they people who don't need your service? So who are the 20%? Because that could be quite significant if they're vulnerable.
Yeah, no, that's a really good point. So as you can see, we do tend to see that the coverage tends to drop off as children get a bit older, and that is the case naturally. So obviously when the children are very young, parents tend to be engaged and concerned. So there will always be a level of drop off. In terms of who the 20% aren't, who we're not reaching, I think that's a really good question. Something we should go and have a look into. So we certainly do that around the earlier visits where it's of greatest concern. So for example, the new birth visit, I did have some concerns about how that was appearing to have been dropped. And we absolutely want to know who we're not seeing in that very early period. But yeah, I think that's a really important question. We'll go and
So could we bring that back so that we know who the 20% are? Because it may be that they're not of any concern.
Absolutely.
But there could be that we're looking at people who we don't want to be referred to the match at a later point.
Yes, yeah, absolutely.
My second question is again about a table. Not that I'm very good at that. It's been on page 31 at the top. Talked about smoking. I'm very interested within this group. It's not just smoking, it's the drug taking and the multi-generational drug taking of where these young people do this with their families and their extended families, that we can't be saying that the smoking of cannabis, for example, is something that only happens with young people. So are we collecting any data on that aspect of where the babies are being that? So, what do you think is the, it's probably a technical term that Councillor Davis probably knows. How accurate is that if people are self-recording whether they smoke? So what is are we looking at possibly 10% more than are self-saying that they're smoker, or are we possibly thinking it's a bit lower? So how real is that figure in the opinion? Because it is self-reported, isn't it?
It is self-reported. I think we can be very confident, though, in that measure, in that we develop such close therapeutic relationships with those families. So it's such an intensive programme. It's very difficult often for the nurses to get through the door. So they spend a great deal of time trying to engage those young people. But once they're there and they've built that trusted relationship, they're very open and will disclose information around risk-taking behaviours that are probably more significant in some ways than smoking. So, for example, as you talk about drug use, that is another issue. We do see elevated rates of drug use in these families, as you say, and cannabis use is a particular concern. And we'll often see that the young parents will talk about cannabis in a positive light as self-medicating. So there is some specific work there. So I do have the data around that. I haven't put it into the report, and I'm very happy to provide that, but we do collect that data. And we've actually identified that as a theme to come to one of our next board meetings. So every 6 months we have a board meeting where we take a particular theme, smoking has been one of those. We have a multi-agency kind of view on what the issue is and try and decide what we can do to try and improve that situation. And looking at substance use is going to be our next thing.
And just finally, I'd like to say how impressed I am with that 100% immunisation. It's just really, you really have to be congratulated for that, because I think we are all suffering from a sort of a vaccination tiredness. I'm sure there is somebody who's got a word for that, but is it fatigue, vaccination fatigue? But that is so impressive, so well done. Thank you for the report, it was really enlightening.
And I'll pass that back to the team. I've actually taken all these services in the last week, so I can't take any credit for it. I'll pass that back to the team.
Thank you, Councillor Shelley. And we know there'll be actions around the data, so then they can be shared with committee members. Next one on my list is Councillor Hopkins.
Yes, thank you. I think one of the questions I had was largely answered, which was it's one thing offering home visits, it's another people taking them up, and it's that to me some of the risk is attached to the people who don't take that up, because we have no idea what's going on there. In the same vein, children who are not in, who are being home educated, again, they're not able to participate in anything to do with school nursing. So again, issues are likely to be missed in that. So is there any, apart from waiting for the government to actually legislate and hopefully pretty soon reach a register of children who are not in conventional education, is there any way of picking that up that we're aware of? Because we know that the children have been born, hopefully, because their birth has been registered, and it's then, is there any way of keeping track of the people who we're missing?
Yeah, sure. That's a good question. So I think firstly, just going back to the children we're missing, so the contacts are obviously offered to all families, and as you say, the uptake isn't always there. So the model we have in Swindon is a really strong focus on that antenatal visit, so the first visit in pregnancy, and all of those are done by a qualified health visitor and are done in the home. And the reason we do that is for a really robust early assessment of what that family unit is looking like. So that's one of the first things we do. And so, for example, if a family had been identified through that process or at any of the subsequent visits as having potential risk factors or known risk factors, then there would be active follow-up. So I should have said that earlier. So there is a level of safety there. The other level of safety, again, around the kind of 2 to 2.5 year check, is that we know we have a good proportion of children eligible for free childcare in childcare, which is another protective space in terms of eyes on those children. Home educated children, I agree, there is a real gap there. So whilst we will see a good bulk of children in early childhood, albeit not all of them all the time, once they get to school age, there is less line of sight there, and as I say, there isn't that kind of standard offer as there is in health visiting. So I think, there is a risk there and there is a gap. We do work closely with the education welfare officers, so those that do have contact with some of those families where they're electively home educating, and ensure that they are able to support children where a need is identified, but it's very much based on that coming forward as opposed to having external sight to children. So yeah, it remains a gap. So.
If I can just ask a further question. When it comes down to smoking and substance abuse, I have to say from another role that I'm involved in, a lot of the breakup of families seems to stem. There's a lot of substance abuse sometimes in those histories, which is really difficult. I think firstly on smoking, and I'm asking something quite general, I suppose, is the tendency for people to recognise the danger but not be able to do something about it, or not to recognise the danger, in which case there's no chance they'll ever want to do anything about it. Because how you approach dealing with smoking is slightly different according to which category people are generally in. So do you see the problem as being greater in one area than the other?
I think I said it's probably a mixture of both. So, you know, there is obviously general awareness that smoking is not a good thing for you, but yes, when you grow up in a household and it is normalised within your community, within your social circle, that, you know, people smoke and they're all fine as it appears, then, yeah, absolutely, there is something around sharing information, making sure people are aware of the dangers. But I think particularly, you know, when we're looking at cohorts like this one, where there is so much going on in the lives of these young people, being able to make a big behavioural shift like stopping smoking is really challenging. So, you know, they'll have a whole load of other things going on in their lives. We see really high risks of domestic violence in these families, really high mental health problems, and maybe as well to add to that as well. So sometimes being able to quit smoking where you see that as a way to help you relieve stress, as a coping mechanism, can be really challenging when you're facing that kind of wider adversity. So I think it's really complex, and I think it's often a mix of the two.
Thank you. So,
Councillor Quigley?
Thank you. I've got about 3 questions in one, but I'll be as quick as possible. Is that okay? Yes, sure. I was really interested in the named school nurse. I thought that's absolutely fantastic. And I know it's been rolling out since the beginning of the year, but I wondered, does every school now have a named school nurse?
Yes, they do.
Wow, that's amazing.
I should just clarify, a named school nurse, they do not have one each.
No, I get that.
It's not that many. Yes, there is one named person.
But one might cover a few.
Yes.
And I suppose I was kind of thinking alongside that in terms of the 70% of contacts being in a kind of mental health context.
Yeah.
I was interested in terms of when they're thinking about the self-harm pathway. Is that in collaboration with other partner agencies like CAMS? I suppose similarly to what we talked about with social care, because sometimes there can be a bit of a reactiveness, I think, from the school nurses in terms of referrals into CAMS, when we know that about 80% of young people are self-harming at the moment as a way of emotional expression. It wouldn't be at kind of CAMS level. So I just wondered, is that a broader kind of systems level thought process, if that makes sense?
It makes perfect sense, and yes, it absolutely is. So I think there is growing recognition that there is much more support needed earlier on. And actually, I think the school nurses could play a really good role in that. So that is an area of challenge we put back to them to say, actually, what can we do differently in this space? If this is where you're seeing the majority of your demand, what we don't want to do is just refer all those children onto a waiting list when actually that's not necessarily what they need anyway. So they have provided me with some good case studies around some low-level intervention work they've done with children, so we know it can be done. It's just the age-old problem of trying to release that capacity to focus. But I think there are definitely opportunities there. We can look at group-based work, for example, and actually going back to the workforce question, which was posed at the beginning, we've done a lot of work in health visiting on a skill mix model. So, you know, that would help us to lead services, but with a range of other professionals. And I think, again, we can move into that space in school nursing so that we've got broader reach and capacity to do some of that lower level work.
Thank you. Any other follow-ups? Okay, so it's going to be Councillor Howard.
Thank you very much. The table on page 29, it doesn't actually list about the antenatal contact, does it?
No, it doesn't. So the trouble with the antenatal contacts is, and I've got to be completely honest with you, I can't quite get my head around this myself as someone relatively new to it, but we don't have a denominator for it, so we can't provide a percentage. So we're monitoring the numbers of antenatal visits that we're conducting, but it would just be a number in isolation. So we're not able to compare that nationally. There is no national collection on the antenatal contacts. So
we do how many offered compared to how many taken up.
We could absolutely do that, and I've also asked them to look at, you know, is there something we could use to give us an idea, a sort of best estimate, if you like, even if we don't have a hard denominator. So yes, that's an area we've already put back soon to ask if we can do them.
Okay, thank you. I'm sure you're better than Roger anyway. I'm sure we don't aim to do everybody.
No, to be honest, the antenatal contacts have been a challenge, I gather. So I think there's been some good progress made in that space, but and again, this is, I think, part of the issue when you've got nationally reported data, that's where the focus can be. So I do think we've made a lot of progress in that space, but as you're saying, I'd like to see some assurance around, do we think we're reaching what people should be reaching?
Yeah, I think even if it's just how many we did last year compared to how many we do at the end of this year or something, that would be helpful to see how it's building, the picture. And then another question was about 3.8, the home, the first home visit, which I guess is a new birth taking place, well, all the antenatal contacts at home. I just wondered, have we monitored engagement since it's moved to coming to a venue? And where are our venues? Are they accessible? And just wondered if that has, made a difference to people who to go somewhere. Some people might prefer that because they've got tidy their house, like they think they should, they don't have to, but they do. It might be a bad thing, I don't know, but also, are they accessible? Are they in the town centre where buses are?
Yeah. So, yes, so you're right. So the antenatal new birth visits all are conducted in the home. So that is because it's reliant on the assessment model and making sure that there is good line of sight on the family that's happening in the home. And also with the new birth visit, obviously recognising that some of those families will only just be home from hospital. So those always happen. The clinic visits are then only for our universal cases, so where we have no concerns. If there are families who need it, a bit more targeted help, they will receive home visits as well. So that could be for any reason, and it could be that they can't get to a clinic for whatever reason that might be. So there are still home visits available for families, either where there are concerns or where they can't access a clinic. The clinics are predominantly run in Penhill at the moment.
It's not that easy to get to, is it?
Yeah, it's obviously sort of great for the local community, and we do have parking there. But yes, it's one of our key challenges. To be honest, is having those community venues.
It's quite a drive, or quite a bus ride with a 6-week-old baby.
Yeah, absolutely. Yeah.
So do we know if it's increased or decreased?
It's not affected coverage. So our coverage has remained largely in line with the national average, and it goes through peaks and troughs as you'd expect. But no, we've not seen any particular drop off. And actually, I think we're really proud in Swindon that we've managed to maintain those face-to-face contacts. So during the pandemic, obviously a lot had to move virtually, and a lot of areas are still conducting some of those visits virtually. So they're not even seeing the families face-to-face, whereas that's something that we've been keen to get back to and maintain.
Yeah, that's my final question, to follow up on Marianne's question about the 3.15. School nursing, isn't it? Yes. I just wondered, are school nurses aware of like the new youth centres that we've opened in terms of liaising and getting young people involved in that, and the way and other organisations that are there to support young people?
Yes, absolutely. Yeah, they're very, very much engaged with the community groups. They've been doing some work over the past year at trying to look at what their holiday provision might look like. So traditionally they've only been available during school times, term times. So working with some of our community-based partners around access during the holidays and ensuring that they can still refer in, they're still available should young people need them. So yes, they do work closely.
Thank you.
Any other thoughts?
No, that's something.
So Councillor Crook next.
School nurses, how many schools do they cover each?
Quite a few. I'd have to work it out. So I think I'd have to go and check, but it's probably about 9 or 10 each.
Okay. So how many nurses do we have?
Again, I think it's about 9 or 10. I'm so sorry, I don't know. I've only just started in this role last week, so I haven't got the exact numbers. But yeah, it's a relatively small team. Obviously, we've got around 90 schools.
Just, having to cover 9 schools, and we've got 9, it's quite a lot.
It is, yeah, it is. It's a real challenge, and I would say it's one of our more significant challenges to the service, especially where we're seeing, increased development across the town and new schools opening. Unfortunately, the funding formula for the public health grant looks at the under 5s to base that our funding on locally, and where we're seeing the growth is in the school-aged children. So it is a real challenge to continue to kind of meet that level of demand. Like I said, I think one of the potential solutions is looking at a greater skill mix model within that team, so that it's led by professionally qualified school nurses, but actually we've got a range of other staff to enable that kind of broader reach and to be able to work with more families, but more schools as well.
Okay, thank you for answering the question.
Thank you. I'm just quickly going to ask if there are any questions online. Yeah, Councillor Perry?
Thank you, Chair. I just wanted to follow up from Councillor Cook's question to ask if we could have circulated to the committee the breakdown of how many nurses there are per secondary school and per primary school, please.
Yes.
We'll not do that.
Thank you very much.
Okay, no worries. Now over to Councillor Clifford Green.
I'm really sorry, I remember my other question. I know that the National Childhood Measurement Programme is obviously mandated. I was wondering, and you might not be able to answer this question, if there's a sense of how they are framing that, especially to the Year 6 pupils that they're doing that with, just because I work at CAMS in eating disorders, and we see quite a significant number, even in Year 6, of young people who are involved with that intervention have become very concerned about their weight and shape. And I just wondered if there are any more broader thoughts around the kind of culture of how they're doing that with the slightly older primary school children, if that makes sense.
It makes complete sense, yeah. So I do know that a number of years back there was a review of the letter that's sent out. So, the children obviously weigh in school, there is an option to opt out of that and then they'll receive a letter. And that was very much reviewed with a kind of trauma-informed lens and thinking about how that messaging is delivered. And I would say the wording of that letter is very good in Swindon. It's certainly better than where I live, which is a bordering area. Again, very happy to kind of share the content of that with you. So I think there's that. I agree that there are issues, shall we say, around the programme. Another thing we're considering is that's all very well, and that's data that is important at the national and the local level for informing what we do. But it doesn't necessarily sit right that we go out, weigh a child, knowing them as carrying excess weight, and then don't do anything. So again, I think that is something that we need to have a look into, to have a think about, is there an offer beyond that?
Thank you. Any other questions? No, I have a few questions. So in the report you mentioned that public health piloted a new program when it comes to recruitment, where they share the interview questions in advance. So I was just wondering, what is the outcome of this pilot, and if you plan to roll it out?
Yeah, so the teams are now doing that as a matter of course, and we've shared those findings with HR. So the general feedback has been that it's been welcomed by candidates. So from a range of perspectives, so particularly in terms of neurodivergence and also those where English is not necessarily their first language. So and also more broadly, so from other candidates as well have said that they valued that time. So they're not giving them a long time in advance, they're giving slides of questions just before the interview, so 15 or 20 minutes before, so we're still looking for a fairly immediate response, but it just gives people a chance to kind of collect their thoughts. So yeah, it's working well, we're continuing to do that, and as I say, that's been fed into our HR team for wider considerations as well.
Thank you. Do you know any other innovative pilots in this space?
We have quite a few. We've got a brilliant clinical lead, I have to say, in the service who thinks very broadly. So the data at their best, as I mentioned earlier, has been very well regarded. We're working with a number of areas nationally now to develop their father service. So that is a particular area that we're really proud of. The clinic model was relatively new. The skill mix model was a new thing at the time in Swindon. Lots of areas do that now. But I would say the service continually develops and innovates as we go. Another area of innovation at the moment is we're looking at some of the timing of the contacts. So what we do see in Swindon, and again this is replicated in other areas, is that some of those contacts are later than the nationally mandated timeframes. But what we're hearing from families is that actually they welcome that. So what they might see, for example, in the new birth visit is literally their midwife will come in the morning and the head visitor will come in the afternoon. And then they won't see anyone again until 6 to 8 weeks. So they're actually saying by seeing the health visitor a bit later, it's spreading out contact across the system. And similarly, at that 6 to 8 week point, they'll see their health visitor, but they'll also have contact with their GP to have a mum and baby check. So again, they're saying actually seeing the health visitor a bit later on is more beneficial, otherwise you don't see anyone at all unless we ask for it until 1. So we're piloting that at the moment and having some external evaluation on actually whether those timeframes at an extended range make better sense for families and for the system, because that is slightly outside of the national guidance. So that would be interesting to see if that kind of theory is proven through that evaluation.
Yeah, I think that's really positive to hear. And also the report talks about improving access to people with protected characteristics, but also thought that there are still challenges in this space. So what steps are you taking to improve accessibility?
I think it's an ongoing challenge. I don't think that there have been, that I'm aware of, and again, I will check this in terms of caveat at this point, but I'm not aware that there are particular issues, but it is about maintaining that constant lens. I think there are some challenges, I think particularly for school nursing in who they're seeing. So they will see more girls than boys, which again is the usual case. So how can we increase access to health services and support for our boys and young men? I think their cohort is predominantly white. And again, how do we reach other ethnicities and what is happening there? And is that around the fact that the majority of the need is around social and emotional mental health, for example? And therefore, you know, is that need not being sought because we're not providing the services in the right way, in a culturally appropriate way? So I think it's an ongoing piece of work, and it's something that, again, I know the services are really keen to continue to explore.
Thank you. Also a question around risk, where it talks about sustainability. So it might be a new impression for Council Grant, and it talks about the financial pressures on the service. Obviously, the population is growing, there are more complex needs, the grant is not really increasing, so the report talks about bringing more efficiencies. Then how do you ensure that those efficiencies are not actually impacting the quality of service?
Sorry, Chair, are you talking about the overall public health grant?
Yeah.
My understanding, and Karen, if I'm wrong, is that that has slightly been increased in the past year. It is a worry, let me put it like that. Don't think there's going to be any indication from government at present that the public health grant will be increased substantially in the next round, which I'd be obviously being public health. We want to see, because all the stuff that Caroline has talked about, we'd obviously like to continue and go further. But we would need to look at the whole of the public health sector. We do have, within the Health and Wellbeing Board, we have three priorities, which are dealing with smoking and alcohol, mental health, and one other that escapes me at the moment. But those are priorities within the it's drugs. Sorry, drugs. Issues of drugs. How we deal with those that would need to be focused on. But clearly, the public health, the whole public health sector covers an enormous amount of ground, and there's only a limited space in which we can spend our money. So we do have to prioritise. So I mean, it may well be that this committee might want to look at how you might want to feed into how we prioritise the public health grant. Always in the knowledge that much of what public health do is statutory, and we have to do it. But there are ways and means of spending money outside the statutory provision.
Thank you very much for that. And lastly, just a feedback. The report was great, it was very comprehensive, and it was full of statistics, but I think what we also usually like to see is bit more qualitative feedback. What actually users of clarities are saying, that helps us then to perform better scrutiny. So going forward, if you could include that in your reports, it would be very much appreciated by the committee. Any other questions? No, so I'm just going to ask the committee members if there are any follow-up items they would like to look at. So I think we focused quite a bit on smoking, substance abuse, and also those the suggestions around prioritization of public health funds. So how do members feel about those two items, or do you have any other suggestions? Cecily?
I understand the smoking ones are concerned, but I question from what the officer said, how much impact we can have or expect them to take responsibility for over time. So I think it's an interesting statistic to look at. But from what you're saying, and correct me if I'm wrong, all they can do is explain the dangers of smoking and hope that the parent decides to stop. There's no other intervention. So I'm not convinced that it's something that is necessarily worth tracking in detail.
Okay, are there any other views? Councillor Quadri?
These might be my biases, but I was more minded to think about the naming nurse in schools and the access to that and the wider impact on broader systems such as CAMS and mental health and the infrastructure around that. But that's just what I'm thinking.
So any suggestions?
I'd agree with Councillor Quadri. Actually, I think that would be interesting. It's getting where we are at the moment with named nurse is a really good sort of first step. It would be good to look at that.
Thank you very much. Any other views from members? This is compliance, so then we're going to look at health nursing camps and the suggestion by Councillor Quadri. Yes, apologies, Councillor Perry.
Thank you, Chair. I just wanted to echo what Councillor Lecoit-Grenny said. I'm in full agreement with that.
Brilliant, thank you so much.
Thank you.
To include accessibility, to include, access as well.
Still in the same report. Yeah, could we do that? Okay, thank you. So what we will do, we'll just review the forward planning, see where we can implement it. So thank you very much to Councillor Grant and Caroline for discussion tonight. Thank you. Thank you so much for coming.
Mr. Chair, Lisa sent her apologies. She had to go out for an emergency, so it was work issues. So.
Let's go from the top. Thank you. Right, so this leads us nicely. You've got a committee members content to carry on the meeting.
Yeah, just. Oh, sorry. I'm just standing up to.
Would you like to have a 5-minute break before we go?
That's great.
Okay, so let's do a 5-minute break.
Michael tell you. So sorry, how do you get to write on? Yeah. Because I can't sort of.
Mike, you're having a text.
I haven't got that. Yeah, how do you? Well, I get things. Yeah, but it's in the, well, why not? Well, it's just, why have I got it in?
Every single thing. It's just.
Are we,
Yeah. I wondered if it's affecting the.
Yes, so we're gonna reconvene the meeting and the next item we have work program. So in relation to next meeting in May, so we have a few items. So we're gonna look at sufficiency of placements, right to the right person, this was an action from our one of the first meetings where we requested an update, so that's going to come to May meeting. Also, we're going to update on some inspection, and the bigger item is going to be prioritization for adult social care and public health for the work program. So Claudia has already sent us some items. I would like to encourage you all, if you could also send any suggestions within the next 2 weeks. So they can be added to this item. And I think in a meeting what we can do, we can then maybe the voting system will be decided items. Yeah, is there anything you'd like to add, Claire?
I would just say, so expecting to get our CQC report sort of mid to late May, there may be some things in there that will help us to make some decisions about other areas of focus. But no, otherwise I'm quite happy to do so.
Thank you very much. And then we're just gonna add with community services the reports we covered tonight that we made follow-up requests. And I think that's it. Are there any other questions around the work program or any suggestions? No? Perfect. Thank you very much. We can close this item. And the last item, we have just an update on actions. Are there any questions? Are members happy to know the report? Yeah?
Yes.
And are you happy for any completed actions to be removed from the report?
Yeah.
Yeah,
Thank you very much.
That would be great.
Okay, thank you very much. So that was the last item, so I'm gonna call this meeting closed. Thank you very much for your time and discussion.
Thank you.
Thank you.
Thank you. Good night.